Welcome and good afternoon, everybody, to the last in the current series of the winter webinars being delivered by Healthcare Improvement Scotland. If we can move to the next slide, please. For those that don't know me, my name's Jo Matthews. I'm Head of Improvement Support and Safety here within Healthcare Improvement Scotland, and delighted to have you join us today. The focus of today's session will be hearing from 3 boards and their work to support maintaining and delivering quality and safe care at the front door. We recognise the incredible challenges that people are facing at this current time, and absolutely recognise that in being able to manage and maintain quality and safety is incredibly challenging. So the real purpose of today's session is about hearing from these teams and the work they're doing in attempts to try and achieve that. So if we move to the next slide, please. I'm sure everybody is aware of the team's etiquette by now, but just in case not, we want to ensure that people are able to get the maximum impact and value out of this. So it will be an interactive session. So please do pop your questions or comments into the chat box, and there will be an opportunity for you to come in at the end of the presentations to ask any questions that you have of our presenters today. Whilst our presenters are speaking, I'd appreciate if you keep your camera off and your microphone muted. The session is recorded, and please make sure if there is somebody who's not able to join today that link is made available to them. Just now, to test out the use of that chat box, if you could pop in where you're actually tuning in from, it would be great to see where people are joining us from across the country. So if we move to the next slide. So I opened this winter webinar series a couple of months ago now, and really the focus there was about embedding the essentials of safe care into the work that we are delivering on a day-to-day basis. And this is really just a reminder that what you're going to hear over the next hour or so absolutely addresses all of the key factors within the primary drivers of the Scottish Patient Safety Programme's Essentials of Safe Care. And the link to the Essentials of Safe Care is going to be made available within the chat box again. But as you listen to the speakers this afternoon, you're going to hear about person-centred approaches, communication within and between teams, the building of that culture of safety and that prioritisation of safety at all levels across the system, and those clinical processes, safe, consistent and reliable. And that really is the foundation in which we want to ensure that we are supporting that delivery of safe care. So we have a really jam-packed session this afternoon, and with no further ado, I'm going to introduce our first speakers from the Scottish Ambulance Service, Alison McGough, I hope I've said your name correctly, Alison, and Gordon Riley, and welcome them to our webinar. So over to yourselves. Thank you.
Thank you very much for inviting us to speak today on the challenges we face within the Scottish Ambulance Health Board on patient safety at the front door and ambulance delays at the emergency department. Can I have my first slide up, please? The next slide, thank you. So it's a picture of, as you can see, ambulances parked outside emergency departments. But before we start, can I take the first 10 seconds for you all to just close your eyes and imagine the last time you heard and seen an ambulance and an emergency response blue lighting with the sirens in your area. I'm guessing you're thinking the same as me. Somebody is in their greatest need. Somebody needs emergency assistance and care of that medical need. I'd now like you to, again, for the next 10 seconds, put yourself as a member of the public making that 999 call for emergency help for a loved one or yourself in your minute of need. To meet our experienced call handlers who will navigate you to where you are, what the problem is, and how long that ambulance will take. Within Scotland, we are meeting our median of cardiac arrest and immediate life-threatening calls, so we are within our response times. It's not the same nationally, I'm afraid. So these unprecedented challenges we face within the response times to our members of the public in their minute of need has become a new challenge that we face within the ambulance services across the United Kingdom. I'll go on and speak about the national issue, patient safety, as well as some other aspects that are an effect of this current situation. Just let me reassure you that within the Scottish Ambulance Service over the last 2 years, we've been working very hard on and integrating into different tiers of healthcare with our team. We've employed approximately 500 other staff to help support this. We work in different areas within healthcare, for instance, embedded in primary care, embedded in urgent care, and also within our clinical hub, we offer telephone triage and remote telephone triage. What you don't see on this slide is the patients that don't come to hospital because of our innovation to looking at patient safety and to also engage in that collaborative of working across the health services to provide support to our peers, colleagues elsewhere. But also what you don't see in this picture is that the patients and the public that are waiting for that emergency ambulance. Next slide, please.
So no doubt you've seen the press today. The NHS, unfortunately, is in the front pages of many national newspapers and on the television. And the message that we're seeing, and we have been seeing for some time now, is that there are delayed discharges, a lack of flow in the hospitals, and ambulances are taking longer to turn around and respond to emergency calls. Unfortunately, our patients as well are having to spend long periods of time in the back of an ambulance, and that's delaying their definitive care. And as Alison alluded to earlier, ambulances that are stacking outside a hospital are unable to respond, although we're doing really, really well with immediately life-threatening calls. Potentially, if you've got an elderly relative who's fallen and needs assistance off the floor, that may take some time. But it's not only a Scottish problem, it's not only a UK-wide problem. Healthcare systems around the world are experiencing the same issues. For instance, America, Canada, and Australia. And we have an example of some research that's being done at the moment. And it was looking at how outcomes are affected on patients who are waiting outside a hospital. And the outcome really isn't that great. We're seeing increased harm to our patients. Patients are dying, and also, surprisingly, patients are reattending with the same complaint. And that's putting a burden on the work that we do as well, because we're failing to treat people effectively at the right time, at the right place. So the study, I think, correlates with some research in Britain as well. The last that I read, there was in England, they're experiencing between 6 and 10 deaths, which are avoidable each day with patients in the back of an ambulance. So the bottom line really is, and we know this, that timely care gives us better outcomes for our patients. Could I have the next slide, please?
So how do we work in partnership? What are we doing to make it better? So this is a snapshot of our C3 National Web hospital arrival screens. Every health board, ED department, medical receiving department, and flow coordinator within the health boards have got access to this, as well as our control and team leaders within the regions. It lets us know what the activity is in that region and what is impending, what's coming in, and also the activity that may come in. It allows us to work with our health board colleagues to get prepared for any incidents that we see there's a big influx coming, and we can get prepared for that ambulances coming. As part of the national drive, we want to achieve approximately 70% of arrival to handover and then to go back on. At the moment, we're not achieving that. It's a lot of issues around that, not just the lack of ability to come into the hospital with our patients, but also compliance for our staff and the communication between the two. But it is improving. We've got clinical team leaders and halos at the front door to help assist with the flow, the patient safety and the staff welfare around this. And it also helps coordinate turnaround times. Hospitals all over are working with lower discharge profiles than expected for this time due to pressures. They're also working at high capacity most of the time. Everybody's quite tired and exhausted and feel flustered about where they get the next bed for the next patient, and patients are still sick. I'm going to go through some of the snapshots of the hospitals just to see how it can change. There are different colours on the snapshots, as you can see, and I've alluded to the ILT and cardiac arrest are actually purple calls. Red, amber and yellow are still emergency calls, but different categories, and the green calls are scheduled transfers that have got agreed patient acceptance to the hospital. The staff within the healthcare support health and social care partnership, A's and E's and secondary care hospitals as well as facilities all meet daily as a daily system connect and discuss the pressures around the system and try to mitigate daily. Next slide, please. Another snapshot of another hospital, just showing you that there is a lot more arrived at that hospital. So there's 7 ambulances waiting at this moment in time. I think the interesting part is different colours, different weights, but some of our ambers are waiting for nearly 2 hours outside, just trying to get that hospital bed available and get them into hospital. Next slide, please. An even busier kind of hospital with a bigger region, but again the pressure's on every hospital. If there's no beds to take patients into, then that's where the problem can start. But also we want to try and redirect as best we can as well, and that is in the means of trying to get patients to the right place at the right time for the right person. The last slide, please. And we're under control at this hospital, so we're managing. We've not got the ability to decide what happens in every day as an emergency service. We don't know what emergencies may occur. There are troughs and peaks, especially with football matches, concert events, and also any kind of disasters that may occur. But also we've got coming into winter and influenza as well. It's something to take in mind. Next slide, please. The Redesign Urgent Care collaborative, probably about 2 years ago now, via the Scottish Government, had a directive to convert and make flow navigation centres to try and re-establish and arrange pathways for urgent care to try and see if we could avoid front door pressures. This is an example of a Grampian flow navigation centre data. It's taken about 2 years to develop the flow navigation centre with different pathways, and so far the pathways are minor injury units, falls pathways, some ambulatory care pathways, as well as a key one for us is the professional decision support line. This particular test was around call before you convey. It was a decision we made in Grampian to try and take the pressure off the front door and try and improve the turnaround times by asking all the emergency crews within Grampian to call the professional line with any non-life-threatening emergency, and there was a strict criteria around that. It was a 4-week programme. Before they started the programme, we probably had 30 calls a week to the Flow Navigation Centre from our crews. But as you can see from starting the test, the calls have went really quite impressively up, and we've got a mean now approximately 22 calls daily with peaks at the weekend. The outcomes from that are quite remarkable. So we recognise that patients still need to go to hospital and that is the right place for them. But as you can see, there's been a variety of different outcomes. 26% self-discharge with some advice and care at home. 25% approximately back to primary care, urgent care and unscheduled care within the out of hours as well, redirected to the right pathway. And the rest of the percentages were a mix between minor injury units and surgical assessment units, as well as we have an AP car that goes out to the locus and can see, treat and discharge at scene with measures that they can do within their advanced practice. Very rewarding to do this test, and hence that's why the test has continued through the test, getting ready for the next test because of the measures we've found that have been positive. We spoke about turnaround times and we collected data, and as you can see at the bottom left, the median for turnaround times has changed with the tester change. And yes, we have got 2 or 3 peaks there, but we can recognise that peaks to be related to higher calls volumes for both self presentation at AD as well as ambulance calls and staff illness. So it is looking positive for us to try and take some pressure off the front door by redirecting our patients to the right place at the right time for the right person in a timely manner. This has not come easy and it's not a golden ticket, but what it is it's helping us educate, redirect and share that system pressure across the systems that are involved. We do have governance meetings around with the health partners just to mitigate any kind of unforeseen circumstances that may occur from this new model. Next slide, please. Unfortunately, with flow navigation centres and different health boards also, for instance, Lothian, Ayrshire and Arran, Greater Glasgow Clyde, Fife, and also Tayside have had a well-established kind of similar approach for many years with Consultant Connect. We're still finding that every day there are lost hours of responding ambulances to our public in their minute of need. So far, this was a capture on the 2nd of December, so 652 hours and 15 minutes for that day across Scotland were lost hours due to ambulances waiting outside the emergency department. Next slide, please.
So I'd now like to talk a little about how the pressure of work that we're experiencing is affecting our colleagues at work, and how it also can affect our friends and loved ones at home. Our staff are normally used to working in complex and high pressure areas. You can imagine a cardiac arrest or a road traffic accident where it's a complex and dangerous scene. We've got really sick patients. But with our professionalism and the knowledge and skills behind us, we cope really well with this. It's often said, by patients afterwards that they're really thankful for the professionalism and kindness that our crews show to them. But of course, now we're living in a totally different world. It's totally out with our normal working environment, and we're experiencing sustained and intense pressure and just new ways of working. And this is affecting, I think, our health generally. If we think about, often late finished, and it's not only the ambulance service, all our healthcare colleagues experience the same. So we're late home, we're tired, maybe a bit grumpy. We miss family events like, putting the kids to bed, reading them a bedtime story, or maybe birthdays and things like that. Our colleagues are missing breaks, or late breaks, the usual. In the back of an ambulance, it's not easy to have a good, healthy diet, so that's affecting our health and worsening our fatigue. And you can imagine sitting in an ambulance for hours. It's not the most comfortable or ergonomic place to be. So we're experiencing increased musculoskeletal injuries, sore backs and sore necks, things like this. Also increased sickness. So if staff are off sick, that's impacting on the workload for others as well. But more importantly, we're seeing that our colleagues are suffering with their mental health too. So low mood, maybe a bit irritable, less motivated. I'm really impressed how they do it day in, day out, to be faced with the same challenges every day. And this is leading to them feeling anxious and some with depression as well. So it doesn't just affect our colleagues, ourselves, but when you go home and meet your family, you might be a bit short-tempered, really tired, inactive, turn up to work, you're not so sympathetic with your patients, or you might have challenging conversations with your colleagues in the ED. Could I have the next slide, please? So, we all work in the NHS. We uphold the values of the NHS. We try and be person-centred. It's often challenging, and we put the patient at the centre of what we do. We really don't want to harm our patients, but we can see from earlier in this talk that we are inflicting harm on some of our patients. We always endeavour to deliver our best care, and we always try and treat our patients with dignity and respect. But there's a growing body of evidence around moral injury, and this is when we're putting staff in challenging positions, and it's challenging their professional values and some of their moral beliefs. And some studies have likened this to the effects of post-traumatic stress disorder. And these are long-term effects. Affect people in different ways, of course. Some might not be affected. Some might be affected for a short time, some for long times. But we know that compassion fatigue is a real thing. It's been ongoing since COVID. Now, because we're failing in our duty of care sometimes, or feel that we are not giving the best possible care, our colleagues are feeling a bit of guilt, a bit of helplessness. And they're also, when they're sitting outside an ambulance with a very sick patient or deteriorating patient, they're often feeling very powerless about how to help that patient. Could I have the next slide, please? So I don't know if Moggie's.
Oh, sorry.
Oh, sorry. Bob.
Error. So very powerful. Sorry, Gordon. So just in summary, our staff have had to change their management. Once the ambulance wheels stop, this is a patient at the hospital. We've been able, as a service, to adapt, change and innovate to become collaborative and try to engage in the health system pressures throughout every aspect of care and the patient journey. We do have challenges. We're now providing ongoing care in the back of the ambulances and keeping patients safe as we can. We identify with deterioration and escalation with our NHS partners and escalate as best we can. The health boards are considering corridor care and we're cohorting. We're doing everything we can to mitigate this challenging circumstances. Thank you very much for our time. Today, Gordon and I both work on the front line as well as part of the clinical directorate, and we will continue to be there to help adapt, change and innovate and support this challenging pressure. Thank you.
Thank you, Alison and Gordon. Some powerful messages there, and I'm sure your reflections will resonate with many people who are joining the call today. I'm going to now move to our next speaker, who is Gillian McCauley, and welcome Gillian to the webinar, who's going to share work that she and her team are doing to support safety and quality at the front door. So over to you, Gillian. Thank you.
Thanks, Joe, and thanks for giving me an opportunity just to share a bit of our journey with you, of which we're at the very, very beginning. So I'm going to share some details on slides. I was asked to be the SRO in a short piece of work. This came from our what we call corporate PSAG within NHS Lothian. So that's Patient Safety Experience Action Group. So our execs, just around about August of this year, asked me to lead on a piece of work to look at how we support the delivery of fundamentals of nursing care within ED and our trolley assessment areas. So we set up a short life working group representing the EDs, so the clinical nurse managers from the EDs and the associate nurse directors and our head of nursing for QI and standards. Just to by way of background, we have 2 emergency departments in NHS Lothian, and we have at the Western a front door trolleyed area that sees GP heralded patients. So just to set out a wee bit of the context and the scene. Just the next slide, please. So I'll share with you just some data that we've got in Lothian that explains the long waits and the impacts on outcomes, and I guess the fundamental catalyst for us doing what we were doing. Like everywhere up and down the country, we have significant workforce challenges, and part of delivering this was how do we make sure that we get the right workforce to support the delivery of fundamentals of care. Myself and the acute medical director sign off the significant adverse events across the acute division, and we can see an increase on significant adverse events relating to lengthy waits and delays, overcrowding and congestion at our front doors. We have a Lothian accreditation and care assurance system, which we at pre-COVID had started to look at what standards would be applicable at our front doors. We paused that work and we're just at the very early stages of picking that back up again, and that will help us with the monitoring of the work that we're doing here. Next slide, please. And then just if you just click on that again, it will bring up just a wee box it should do. Thanks very much, Gemma. So this is a year's worth of data around patients that wait longer than 12 hours within our emergency departments across NHS Lothian. And you can see that we've had a dramatic rise in those patients that are waiting over 12 hours. The impact of this is far-reaching, not only for the patients, the carers, but also for our staff. And as Gordon describes, that moral injury and that compassion fatigue is absolutely profound and felt every day. Next slide, please. When we look at our average length of stay in emergency departments and front door areas for our admitted patients, we can see that that has increased, and it roughly sits around 8.5 hours as an average length of stay for those patients who are being admitted. And then next slide. And for our non-admitted pathway, we're roughly around an average length of stay of about 3.5 hours. But obviously, as our admitted pathway length of stay increases, that has a direct impact on our non-admitted because of the overcrowding. And as that overcrowding becomes worse as the day and hours and minutes go on, it naturally impacts on the non-admitted length of stay. Next slide, please. Some of the statistics that were shared by the Royal College of Emergency Medicine, and the impacts of those long waits, and similar to what Gordon described when there's delays for offloading. So we know that there's an increased 30-day mortality rate for patients who wait longer than 5 hours. And for every 82 patients admitted beyond 6 hours from the point of arrival, there's one expected extra death. And in NHS Lothian in 2021, we had 27,000 patients waited longer than 6 hours at our front doors, and that 1 in 67 will come to harm who wait longer than 12 hours. So these statistics are really profound in terms of impacts to patients. It's quite unfortunate that we don't have the statistics on the balance side of that in terms of the impact to staff, and maybe that's something that collectively we should look at doing in terms of research and also quantifying that out. But for every bullet point that's here, I think we can equally see a bullet point in terms of moral injury to our staff. These were the catalysts for our corporate PSAG team in Lothian to set out some work. It's not the only piece of work we're doing around the front door, but it's a discrete piece of work particularly focused in on the fundamentals of nursing care. Next slide, please. So what did we do then? And if we look at the Excellence in Care framework, which our Lothian Care Assurance framework sits and mirrors alongside, we set up a short life working group chaired by myself with reporting back into corporate PSAG, and we agreed that we would monitor the implementation of the work that we were doing and outputs through our acute clinical governance route. Our first step in that journey was to agree and identify a workforce that would support the delivery of the fundamentals of care. And just to set that out in context, there's days where in the Royal Infirmary of Edinburgh, we have got patients to the sum of 2 wards worth within our emergency department. So the challenge of running 2 wards and an ED is absolutely profound, and that can't be done without additional workforce. So we have agreed that we would have additional investment in all our front door areas of Band 2 healthcare support workers whose focus will be the delivery of fundamentals of care and care rounding. So that seems really easy, but our next challenge was, given where we are with workforce, how do we get the 20 plus healthcare support workers actually recruited, employed and started at our front doors? So we're on a journey with that, and we certainly haven't got everybody in post that we would like to have in post, just because of recruitment challenges that we're experiencing the same as everywhere else. We've got a Band 4 programme in NHS Lothian, and we've prioritised places for our front door, again to help support the workforce to help deliver those fundamentals of care. And the other initiative that we're doing in NHS Lothian across the board is offering our final year nursing students a Band 4 11.5-hour contract, and again prioritising them to areas in the organisation of greatest need, of which our front door is one of them. So securing that workforce is absolutely the critical first step, and as supporting teams at the front door to deliver fundamentals of care. We then, as part of the Short Life Working Group, looked at our processes, and we had different processes at our 3 front doors, and we've tried really hard to bring them into alignment, developing a standard operating procedure for the delivery of fundamentals of care that define when we start to do things different, and we agreed that once patients get to 6 hours and beyond, there are things that we need to do that are different than we would do in terms of routine delivery of ED care. We had to agree documentation, particularly how we would document care rounding and how we would have a measurement plan that would evidence that we were delivering that fundamentals of care, documenting it, and ultimately affecting improved outcomes for patients. Next slide, please. Just a quick snapshot of one of the versions of our measurement plan, and that some of the things that we were looking on that. It's not everything, but in particular really focusing on how we could evidence care rounding, looking at meal provision, personal hygiene, pressure ulcers, pain relief, all of these things, medication delivery, all became priorities within that SOP for delivery of fundamentals of care. In no way are we accepting that by doing this, that we see that this is the way A&E care will be delivered in the future. And I always think we toil with that from a cultural point of view. I'm an ED nurse by background, and I think at periods throughout the last 25 years, we've all toiled with the concept of having patients who wait lengthy time in ED and that becoming what we would classify as norm. So we're not saying that we want this to be normalised, but we actually are recognising that it's here and now, and for the short and medium term, we as professional leads for service and responsibility and accountability for governance need to make sure that we've got systems and processes in place to support staff to do the right thing. Next slide, please. So just in summary about where we've got to, this is a journey and we're at the start of the journey. I think we're probably just at that light bulb at the very bottom of this step. We've got targeted recruitment for our healthcare support workers, and we know that we've got a bit of work to do to make sure we've got everybody in place that we've identified through workforce planning that we need. We've tested an initial care rounding document, but we've since done some work on that because we felt that while we might be able to evidence documentation, actually the important part is, can we evidence that care rounding and fundamentals of care have been delivered? So we're currently just updating that. We're monitoring the compliance with the care rounding, both at site level and then up through our acute clinical governance route, so that we wrap around the governance support in this. And this is in no way to, I don't mean we're doing this from a real scrutiny point of view, we're doing it from a supportive point of view. So if we put things in place and it's not giving us the results that we want, what else do we need to do as a senior leadership team to support our teams at the front door? And that's absolutely key for me, and I know it's key for our associate nurse directors and clinical nurse managers. We also monitor our patient outcomes through significant adverse events, the work we're doing in SPSP and essentials of safe care, and through our Lothian accreditation and care assurance routes. At our November Healthcare Governance Committee, which reports into our board, we detailed out very clearly the impact that exit block is having on our ED staff and patients, so that there is absolute transparency from a department to board on the impact and some of the things that we are trying to do to mitigate this. It's not the only work stream, as I've said already, that's looking at that wider system approach to exit block in the ED. There are many through the unscheduled care collaborative routes that are being taken forward, but this is a discrete piece of work focused in on those essentials of care in line with the excellence in care framework. And then we've got this logged within site and acute risk registered in terms of being, again, open and transparent around that corporate governance element of that. I'll be more than happy to share with anyone any of the documentation, our arguments for additional workforce and what we've done around workforce in Lothian with anybody else who would be interested, and happy to do that following the webinar. So again, I would like to thank the teams in Lothian, particularly the teams who were part of the Short Life Working Group, but most importantly, the hard-working teams who every day feel the impact of the weights that we've described. And thanks to Healthcare Improvement Scotland for allowing us to share the work that we're doing.
Thank you so much, Gillian, for that incredibly important messages there. And I am sure there are many here on the call today that would be interested in taking you up on that offer of the resources that you're sharing. And also, I think that continued learning as you work through this process, and you're really bringing together a focus on safety and quality, wrapping that governance around it and thinking about the infrastructure that you need it to be delivering that person-centred care, which we know is incredibly challenging to do at this moment in time. So incredibly important information that you're sharing there, and I think we all would want to follow you on that journey and learn with you. So thank you very much for that. We're going to go to our next speakers, please, if we can move to the next slide. So I'd like to welcome Lynn and Zoe from NHS Borders, who are going to have a bit of a double act this afternoon, sharing the work that they've been doing at the front door of the hospital and some of the impacts that they're starting to see from that. So thank you very much, Zoe and Lynn.
Thank you so much. Can we have the first slide, please? So thank you very much for inviting us today. Zoe and I work in Borders, and we've been supporting flow through the hospital by taking forwards a Kaizen approach. So I'll take you through the slides and talk about what we've been doing. So the next slide, please. So faced with very similar problems to everybody else, we have these huge delays, increased delays in our system. Here we're showing delays of over 72 hours, and we're sort of seeing an increased footprint of our beds, a large number of delayed discharges within our system. We've got real problems in terms of access to registered nursing and long waits in the system. And we're really concerned, as our previous speakers have talked about, our omissions in care and the potential harm that we've been doing to our patient group. Next slide, please. So with that background, I was asked to take forward a Kaizen approach within our medical assessment unit. I've previously worked within Lean, having looked at various different pathways, so I was quite excited about taking that similar approach to the floor of the MAU unit. First of all, we looked at what we were trying to achieve. So we had stakeholders from across the workforce, so the senior leadership right down to the staff within the wards, and key staff that sort of influence the flow of patients. And we were looking particularly to get our MAU unit functioning again, because it had changed into a sort of a longer stay general medicine ward rather than a fast flowing medical assessment unit. So our first aim was to try and get back that 48 to 72 hours patient journey within the acute setting. That would then be looking towards generating the flow within the emergency department and getting flow further through into the hospitals, into the general wards. Our objectives weren't ambitious. We were looking for a shorter sort of length of stay of around 10 hours. And so that was our sort of immediate focus, and we achieved that during the Kaizen. We achieved that sort of 10-hour reduction. Now we're currently sitting at 7 hours, but still that's having a huge impact on flow. I'm now working within the medical wards, and we aimed at one day reduction in length of stay, and that's what we're achieving currently as well. So it's not about huge big gains, it's about small wins and just trying to shift the focus to earlier discharge in the day and trying to reduce our sort of impact across the hospital. So we were looking at what was happening in our boarding population and what was happening with our elective opportunities as well. So we've had an impact on all these areas. We've not got long to speak, so I would have showed you some slides and we can share things afterwards, but we've got some impressive data to show you about how we've had an impact on all of these parameters. If you'd like to move forwards. Next slide, please. But I really wanted to get to the nub of what we were actually doing, because I think that's probably what you're wanting to hear about more. So what we did is we went to the floor. So we spoke to the staff, we looked for ideas. So rather than imposing ideas onto the ward, onto the medical assessment unit and now onto the medical ward, we asked them, what were the issues, what were the problems? Spent time shadowing and looking and seeing and speaking to staff and understanding what the issues were. So we placed the staff right at the centre to find out what was going on. And we focused on the flow. So we were following the principles of home first. Why not home? Why not home now? And then applied on top of that realistic medicine principles. So we were saying to our patients, thinking about our patients and saying, why were they staying in hospital? What principles were we following when we were looking at the patients that were coming into us? Did they need to have those diagnostics to have added value to their journey? Very much sort of saying, was the care that we were delivering going to make a difference? So sort of challenging some of those principles around what were we doing with our patients when they came in. And we also thought about our risk thresholds. So we were thinking around the whole journey. So we were thinking, sort of very much making MAU sort of consider what was happening in ED, what was happening downstream, what was happening in the whole hospital. So they were recognizing they were part of a whole system. So if somebody was saying, oh, well, they'll just stay a couple more days, there was a question around, well, why are they staying a couple more days? What would the benefit be of staying a couple more days? So really very much sort of challenging the patient journey and what the benefits were. And that was all done within a safe environment. So we talk about psychological safety here. And what we mean by that is that we, in the multidisciplinary team, which was led by a medical director at that time, there were some quite considerable challenges that were placed in terms of, is that the best way of approaching this? Is there anything else that could be done? What else could be done to support this person going home? So very much talking and challenging the current way of thinking. And what we saw during the sort of the 4 weeks of Kaizen is, rather than a passive meeting, a multidisciplinary meeting, we saw a very active pull that was starting to generate, with people sort of taking much more ownership over actions and ensuring that things were being taken forwards. When I talk about removing waste, that was what came out from the staff. So how do we make sure that everybody has a focus and that we're focused on early discharge through the day? So we use the whiteboard approach, which is part of the DWD. And that's worked incredibly well. We've adopted it depending on which area you work in. So at medical assessment, have one type of whiteboard, got a different type of whiteboard in the general medical ward, because we talk very much to the staff and ask them what they wanted. They've got different meeting times. And so depending on how the meeting works, we talked about the different parts of the patient journey at different times of the day. So it's going to the staff and finding out what works, but always focused on supporting the patient to have the shortest length of stay while still meeting their medical needs. We've also set up wider interactions. So what I've got there is shared intelligence across the quality team, and Zoe's going to talk more about that. But it wasn't just me and the medical director that were working on this. It was the whole of the quality team that were working behind the scenes. So we shared our knowledge and our experiences and all did different parts of the journey. So I'm going to take you to the next slide. And these are sort of the areas that we focused on. So when we spoke to staff on the ward, these were the key areas that we wanted to work on. In Borders, unfortunately, we're still on paper records. We're very hopeful that with our move to Track Care 2022, we should be moving to electronic version, but we started our journey around reviewing the development of a multidisciplinary document. And I'm going to give a big thumbs up to Zoe because she led mainly on this work. But this was about pulling documentation together, having very strong focus on discharge planning, being a multidisciplinary document, very orderly, and being in a sort of much more sort of organized fashion that sort of led to sort of much more readily shared information. In terms of the following the DWD principles, that was the home first, like I was saying, using the whiteboard, having the questions around the multidisciplinary team, ensuring the multidisciplinary team were taking actions and following up on actions, and being proactively pulling the patient through the process. There was a lot of discussions around the Cardexes and drug errors. So we did a lot of work with pharmacy. And now there's going to be pharmacy technicians that are going to be on the ward. And we've got more things happening within the ward itself to support the Cardexes. Again, this is the paper information we have going backwards and forwards to the pharmacists and delaying the journey. We looked at frailty, and we were really keen to get the frailty beds within the medical assessment unit, and that was something that we tested. And we found that we just were not able to ring fence within those 37 beds a frailty unit. So there was some great learning from that testing that's meant that we're now looking and seeing where we can put our frailty beds out with of that setting. And the last bit that I'm going to move on to is the well-organised ward. I'm going to hand you over to Zoe because that's the work that she's been leading on.
Thank you. Next slide, please. So we've, as far as I'm aware, we've got quite a unique setup in our organisation in regards to the quality management team, where we all are based together. We've got clinical effectiveness, research and innovation, risk, person-centred care team, and patient safety. And we all work closely together with the operational team too. But then also using the soft intelligence, like Lynn was saying, when we're actually out and about in the areas, and you can feel, look and smell, and sort of using your head, hand and heart, and not just looking at the data, but what's actually going on in your areas. Next slide, please. Which brings us to our actions in regards to mitigating the risk at the moment under the circumstances, like everybody else has spoken about, which leads us on to the targeted work that we've done in regards to the well-organised ward in the medical assessment unit. And we've also been doing this in the general ward, and actually it's spread to other areas in the organisation, and we're just been sort of focusing on the quality improvement part and the systems and processes. Next slide, please. So then this, obviously, we don't want to reinvent the wheel, and obviously everybody's, when you ask, what can we do and how can we help, everybody's answers is obviously, can you get us more staff? But unfortunately, we all know that the cloning machine is broken at the moment. So instead of, thinking, doing something new, let's have a look at what we've got. And what we did have in all our areas was from the NHS Institute for Innovation and Improvement, is the Release in Time to Care, the Productive Ward programme that was from 2008, and all the areas have this. So we thought, right, we can't get you more staff, but what can we do? We can try and save you time, and we can give you time back to spend with your patients. So obviously we looked at the 5 S's in regards to starting off by, sort, set, shine, standardise and sustain. And obviously we just started off with eliminating everything that didn't need to be in the areas, and we did inventories of storerooms, and we also combined, rearranged and simplified. Next slide, please. And I can just even use an example this week of in regards to the lean and the fundamentals of the 8 processes of waste, because I was pulled from my job this week and actually to go and work in Ward 4, and one of the things that I noticed when I was working there is that the IV fluids in the ward, for example, are stored outside of the ward, and you have to have swipe access. And then staff were asking me if I had access, but I didn't. And then obviously, with your staffing levels, having to leave the ward to go and get your IV fluids, it's obviously increasing your footprint, and obviously this leads us to sort of transport and movement. So today, what we've done is we've transferred IV fluids onto the ward to reduce the staff's footprint and giving them time back. That's just like a live sort of real-time example of going out, working into the areas, actually becoming the staff member, and actually you see things differently. Next slide, please. And here's just some examples of before and after in the medical assessment unit in regards to their dirty sluice, and you can see what they were having to deal with, and obviously things are in cardboard boxes and you can't see, and everything's on top of each other, but the staff are finding this much easier to use now, because obviously everything's labelled, everything's organised, and they can find everything. Next slide, please. And then obviously I've nicknamed this the Room of Doom, as you can see the before photograph, where this is actually a shower room, but it's not a shower room anymore, and it's lost its purpose. In the medical assessment unit, for example, it does need a refurb, because it's one of the areas that hasn't been able to have a refurb, because it's a very old hospital. But they have issue with their excess stores. So we looked at this and thought, what purpose can we, how can we help? How can we make this a more productive for them and for the staff? And they actually stored their excess stores in 2 different areas. So instead of the stores team having to deliver stores to the shower room and to the other area, they now just deliver all stores into this one room, which is obviously given them time back as well. And then we found shelves from another ward that they didn't want, and then it's now got a purpose. Obviously we need to try and maintain this, so we're putting systems in place of obviously labeling that this is the purpose of this room now, telling them that stores are delivered on a Thursday, and just getting everybody aware. And the other things that the medical assessment unit has done to sort of mitigate the risk is they've hired a housekeeper, which is a new role, so hopefully they'll be able to maintain it as well. Next slide, please. And other systems that we've put in place is obviously finding equipment, and just like say if you're in a workshop and you've got your tools, and obviously once you've removed one of your tools, and you can see that that's where the spanner used to be, sort of using shadow maps, and obviously nobody can ever find the bladder scanner, so obviously we've got signage of this is where the bladder scanner lives, and we've all worked together in regards to sort of mapping out where equipment is supposed to be on the wards. And then obviously people who are deployed to the wards, under staffing circumstances, hopefully they'll be able to see this. But we've also made the signage so that we can spread this, so that it's not specific to the medical assessment unit, but we can spread it to all the other areas that have this equipment too. And we have been able to save time, for example, for stores. They were short-staffed last week, but they actually saved over an hour of their time putting stores away, and stores have let us know about how much money we've saved as well, and it's thousands in regards to rationalising what we use. And stores have actually been working with the emergency department And last week they saved them £1,300, but I've never seen the senior charge nurse in the last 2 years so excited when she met me in the corridor, because they've helped them in regards to their stock and reorganised it so they can actually find things. And that's what we've been doing at the moment. It's a work in progress, and we're all working together, and everybody's pulled together really well in regards to this. And it's kind of spreading. Even the Western General in Edinburgh were on the phone to me the other day asking about it. So I'd like the whole of the NHS to do the well-organised ward. It would be amazing. Thank you.
Thank you very much, Lynn and Zoe. I think from the comments in the chat, your ambition there, Zoe, is supported. And I suspect that you're going to receive a number of different contacts, certainly from ourselves within his as well as we progress some of this work too. I think also what you shared there in relation to the Kaizen piece, fantastic examples of actually applying different improvement methods to support that change and really starting to see the impact of that. So thank you so much. We're now over to the Q&A section of this webinar, and I'd ask our presenters to just come back online. And Leslie has been monitoring the chat box while we have been hearing from our presenters. So over to Leslie for comments and questions.
Yeah, that was the chat box. I was struggling to keep up at one point, but there's definitely been lots of thanks to the speakers, just in general, how informative they found the sessions. Some folks saying it's great to see Releasing Time to Care being sort of revisited, and Julie Coyle has said that she really liked the after photos, that she found them really pleasing. Una McFadden, she was also saying that it would be good to consider how the productive ward could be used to enhance induction and support for locum doctors who are unfamiliar with the areas as well. But in terms of the questions, Gillian, I know you've been answering some of them in the chat box, but one from Tracy McGann is what systems, no, it's not for you, Gillian, it's actually for our ambulance colleagues. What systems are in place to support staff who are working through the experience of moral injury? Obviously, it was quite a powerful session.
Yeah, will I take that one, Poggy?
Yes.
Yeah, so we've got numerous resources that are available to our staff. You think back in the day, you used to just go to the back of the garage and bawl your eyes out and then come back to the mess room and have a cup of tea. But things are much, much better now. So we've got multiple resources that the staff can get access to through a system called ATSAS. We've got an employee assistance program, which can allow face-to-face support for staff from mental health professionals. We can also signpost our staff to third sector agencies that are experts in all sorts of, financial difficulties you might have, relationship difficulties, as well as mental health. And we've got self-help applications as well that people can dip into, how to recognise and manage stress, well-being, as well as the other signposting to support mechanisms. There's also a service chaplain that can help with spiritual needs. And we've got a well-being line as well that staff can contact directly and gets help immediately. And in addition, we've got a psychological resilience hub that we can signpost staff to. So it's quite comprehensive.
Thank you very much, Gordon. The next question was for you, Gillian. I think it was from Nancy Burns, and she was asking if the additional Band 4 posts proposed were to replace registered nurses, or would that be in conjunction to?
So I answered that just a wee bit further down, Leslie, but what we are doing, a whole other presentation that I could probably give. We've done a study of over 300 hours of observations of care, and from that we are looking at what is the suite of staff that's required in clinical areas. So we're not replacing anything, we're augmenting, we're making sure that we've got the right person doing the right job, releasing time for the registered professionals across all professionals groups to deliver the bit that they're trained to deliver. So it's an augmenting of rather than a replacing of.
Thank you.
And I think that can be reflected also in the working borders, and really thinking about the pharmacy roles that you're bringing in as well, and really start to think about that workforce differently, to ensure that the right care is getting to the right person at the right time by the right person.
Okay, thank you. Next, we've got a question for Una McFadden. And she's asking, do the care rounds, when you're looking at your care round in an ED, does that include ambulance-based patients?
Ambulance patients that are out in the ambulances. So we don't, we try and offload our patients. We don't stack in Lothian, so we try and offload. So they all tend to be in the emergency department, hence why we've got 2 wards worth of patients in there.
Okay, thank you. Una's obviously got her thinking cap on again, because she's also, wait to see, are there any data of patients who could have waited in their home until they had reached the front of the queue for space in the ED, so that an Uber-type AI system could then organise transport to take them to ED when there was no anticipated wait?
I don't know who's going to answer that, but my question would be, if they can wait in their home, do they need to come to A&E at all?
I can answer some of that for not emergency department work, because you're right, Gillian. The emergency department is for emergencies, but within the Scottish Ambulance Service and within partnership in health boards, we do have timed admissions that are planned. Like, for instance, our frailty pathway, we're linked into hospital at home, and sometimes we do not take that frail elderly woman that's had probably a fracture to her hip, but is not life-threatening and is comfortable and tucked in our bed at 4 o'clock in the morning. So us as advanced practitioners will reconnect with the staff in the care home facility, make sure that the patient is well and hemodynamically stable and comfortable with no pain, and will arrange for a timed pathway in the morning in conjunction with our A&E colleagues, probably about 8 o'clock, once the pressures have died down slightly. And we do the same now, similarly, sometimes with our medical receiving colleagues. A lot of the time patients do need to come in, but not at the time to sit for 6 hours out in the side of an ambulance. So we're starting to do that, but not as a rule, and there's no pathway for it. So it's an individual basis, and it's managed by our advised practitioners within their remote telephone triage pathways, and also supporting the flow navigation. Thanks.
Thank you, Alison. The next question we have is from Darlene Tuff, and she was asking, how can ambulance handover factor as a key component of essentials of safe care?
I guess that's for both of us, Gillian. So I'll speak about it from a Scottish Ambulance point of view. So we think the hospital turnaround and the ambulance screens are there for patient safety, risk and ambulance availability, but also to prepare staff for incoming as well. We do have a pre-alert phone as well. The second part of the question, I think, we want to work together to make sure we've got a clinical handover that's robust enough to maintain safety inside and outside. It's dynamic, it's patient-centred, and it's really trying to triage that whoever in the department, regardless if they're in the ambulance or in the department, needs the need, they get the next probably available bed. That's kind of some of the measures we've got in some of the hospitals. It's nice to hear that our ambulances don't stack outside, Gillian, but I guess the pressure is then put into you and how you manage that extra load of patients coming in. I think we're just working towards maintaining patient safety, reducing risk, and making sure that the right people get offloaded at the right time in clinical demand.
I think also it's worth noting that we do have escalation plans in place as well. So our crews are monitoring our patients closely when they're waiting outside the hospital. And there are agreed processes so that our paramedics and other clinicians can have a high level conversation with senior medical staff to highlight deteriorating patients so that they're seen in a timely manner.
I'll maybe just come in, Leslie, as well on that, and just as people are talking, and I think if we reflect on the essentials of safe care, handover is part of, Joe, am I right in saying it's in the person-centred driver diagram?
It's also in the communication part
Yep,
of it
yep.
as well, and
you
getting
have
that
seen it.
structure around.
I've definitely seen it in the person-centred one because I'm doing that work for excellence in care. So and I just wonder if there's an opportunity for us here to work collaboratively across the boards with yourself, Alison and Gordon, around, is there an opportunity to standardise things? You're one organisation handing off to multiple parts of the system, and is there an opportunity for us all to work collaboratively to get that a bit more standardised? Because I think that would help us from a safety and quality point of view. And there's also that bit about how do we make sure that we do that at the bedside of the patient, involving the patient in their handover. I know from doing my fellowship and handovers was my project, that absolutely there's benefit to patient safety, quality and person-centredness if we're handing over involving the patient as part of that. So that brings and ties nicely in the essentials of safe care under that person-centred umbrella. So maybe I'm causing myself a wee bit of work here, but I'm happy to connect with people and maybe we could work on that nationally.
And that sounds a really positive note to sort of conclude the questioning part of the webinar. So Joe, I'll hand back to you to wrap up.
No, thank you very much, and we'd be more than happy from an SPSP perspective through the essentials of safe care to be working with that. And I think that there are already connections have been sought, so I think we're already on the way there. So thank you. In relation to this afternoon and the other webinars that have happened, if you click on this QR code, you'll be able to get the links to the recordings for these. And there is also going to be a link in the chat box if the QR code's not working for you. So you can go back through the previous webinars to just refresh yourself or to be able to share them with colleagues. If we go to the next slide, please. And alongside that, it's really important that we get your feedback about what's working in this series and what we can improve. And alongside that, whilst this is the end of this series for 2022, we do want your feedback about what are the topics that you would like us to focus on for up and coming webinars that we'll start to plan in the new year. So we really want this to be informed by what you need to ensure that we are maximising the value and impact for you. So please click on that link to complete the evaluation. And if you go to the next slide, please. Many ways for you to get in touch with us, and please do. I know that often there are reflectors who will come back after the session and have questions. Don't hesitate to get back in touch with us. I'd like to take this opportunity to firstly thank our speakers for their time this afternoon and for the preparation that they've put into sharing this information with colleagues today. I'd like to thank all of the people who have joined the webinar this afternoon for your fantastic participation, your questions and your comments. And lastly, I'd like to thank the HIS team who have supported us, not just in this webinar, but throughout this webinar series. Really appreciate all your support in this. Thank you very much, everybody, for your time today. Bye-bye.